Okay, on to chapter 58. And let's talk about the breast disorders now. Okay. The first part of this chapter is just breast assessment. And I want you to know the most important thing about doing breast assessment, because it is really important to know how to do a good and thorough breast assessment. It's important to teach your patients how to do self-breast exam, and then when to go for a clinical breast exam. Now, don't screw this up, because you're probably going to get questions about this on NCLEX. There is a difference between self-breast exam and clinical breast exam. A clinical breast exam is something that a woman should go for and have once a year and have done by a trained professional, either a physician, an OB-GYN, advanced practice nurse, somebody who's trained to know what they're doing and what they're looking for. The American Cancer Society is now recommending that women over the age of 40 have a clinical breast exam every year. This changes a little bit in women who have high risk, like women who have a known BRCA gene. They have to go a little more often. Women who have fibrotic breast tissue or dysplasia kind of things may be recommended to go a little bit more often. It is also recommended that a woman go for a clinical breast exam starting at the age of 21, I think, and then every 3 years thereafter until the age of 40, when it becomes every year they should be going. So one thing that go to page 1684. This is how, if you are a nurse working in a gynecology clinic or something like that, this is how a clinical breast exam should be done. It takes about 10 minutes and it's very thorough, because what you're doing is you're trying to identify lumps or masses. Malignant masses tend to be hard and they don't move and they're painless. Fibrotic masses, or cysts, they tend to be tender. They get bigger and smaller in size, often associated with the menstrual cycle. They can move. You can move them, like a little ball of cyst in there. So those are some differences when you're doing a clinical breast exam and you identify a mass. It's better news if it hurts and is movable rather than if it's a firm, hard mass that's non-tender. Those are just some signs. But once you identify a mass, then you go for more diagnostic testing. That's the clinical breast exam. I want to then show you, because it is also important to teach women that they should do monthly self-breast exams. And that's on page 1686, and you need to be familiar with how to teach your female patients how to do monthly self-breast exams. And the reason for this is just so that the woman is very familiar with her breasts, so that then if there's a problem, they can seek treatment early. So this chart 58.3 tells you how you would teach a woman to do self-breast exam. Step 1, it's much more comfortable if the woman does the self-breast exam at the end of her menses, like 2 or 3 days after she's done menstruating, just because the breasts are more comfortable. Prior to menses and during menses, the breasts tend to be a little more enlarged and sore and swollen. And it's not going to kill you if you do it then. It's just more comfortable to do it afterwards. It's also more comfortable in the shower when a woman is soapy, because then your hands can slide a lot easier because of lubrication. So step 1, you stand in front of the mirror and just have the woman be familiar with what her breasts look like, and have her note any changes, any abnormalities. Then have her put her hands behind her head and kind of press forward. And what that does is it contracts and tightens the muscle, the pectoris muscles, So you can have the woman identify if there's any abnormalities there. Then she takes her hands down and puts them on her hips and kind of leans forward, and it's moving the breasts forward with the muscles behind there. And then she needs to assess for lymph nodes. The axillary system up in here has got a ton of lymph nodes in it. So she needs to be very familiar with the lymph nodes that are all around in this area. And then finally, the fifth step is to lay on her back and also do a breast exam and see if she feels anything. If the woman has a really good baseline, then if anything pops up, then she'll know exactly what's unusual, then she can go seek treatment earlier, which is the key. You want to seek treatment to find out if it's a malignancy or if it's no big deal. So then the next thing is the diagnostic procedures. So women should go for the annual mammogram after the age of 40. A mammogram, and it shows you on page 1687. Now, I do have to tell you, they are coming up with some new procedures because a mammogram is not comfortable. They put the patient's breast on a like an X-ray exam table, and then they bring down another plate on top of it and mash the breast tissue between these two plates, and then get like almost like an X-ray of it. And it shows a picture, like if you look at figure 58.4 on the top of 1687, you can see the image that shows up from a mammogram, and you'll notice in the top left, see that white dot there? That's a mass. Now, this mammogram shows the physician or who's ever, taking care of this woman that there's a mass in the breast. You don't know what it is yet. You don't know what kind of mass it is. You don't know if it's a malignancy. You don't know if it's a benign thing, but there's something there. So, hopefully if the woman listened to you and followed the prescribed self-breast exam, she identified something, went in for a clinical exam, the physician identified something, sent the patient for a mammogram. Now we know we've got something there. So, this is the other thing I was going to tell you. They are coming up with some new technologies now that don't involve mashing the breast tissue between two cold pieces of X-ray material. And one thing that they're doing some work on this, I know, at Wayne State, is they're using water, like a water tank, so the woman can actually lay on a table thing, and then the breasts are suspended in water, usually like a nice warm bath of water, and then they can get the sonic, the wave sounds through the water, and it's much more comfortable for the woman. And some studies are showing that it's more effective and more precise in identifying masses. But that technology is not 100% out there yet, but I know it's coming. So all the women out there, we can only hope. Anyways, okay, so now we find out that there's a mass in there. So now you have to figure out, what are you dealing with? So then you move to the breast biopsies. And as a nurse, now you start the education, because your patient is going to be nervous. They're concerned, is this a malignancy or is this something benign? And you need to reassure your patient that most breast masses are not malignant, but we're going to make sure that that we know what we're dealing with, and you just start telling them the steps that are going to occur, because it's very scary for your female patients. So you have a couple options. So spend some time on page 1688 and 1689, because, and this will depend on where the mass is, and the healthcare provider that is more comfortable doing a certain kind of biopsy. But the next step is you have to figure out what's in the mass. So fine needle aspirations, core needle biopsies, and stereotactic biopsies, ultrasound and MRI guided biopsies. Those, your patient doesn't need sedation. That is just, usually they will take like a long needle, or some of them are bigger gauge needles, and they go right into the mass. And some of them, like ultrasound or an MRI guided, they'll use the ultrasound, so they know for sure they're getting the needle right in there, and then they'll send those cells to pathology. But the woman, you just need to teach them about what's going on, why we're doing the procedure, what is going to be involved in the procedure. So I do want you to know the different, like, read through the different kinds of biopsies and what's involved. But some of them, like if the mass is deeper in the breast tissue, or there's some other reason they think they might need to go in and do an excisional or a wide margin biopsy, or a wire guided biopsy, then the patient has to be under sedation, and then it's more like an outpatient surgical procedure. So like the excisionals, the incisional, the wire needle, those ones, your patient's going to be also sedated. So now you have to take care of your patient, who you teach them ahead of time. You talk to the family, give the family some security that we're going to take care of your loved one, and this is how the procedure is going to go. But those ones are they're going to be usually done in a hospital, whereas the other ones can be done more of an outpatient setting. But then what they do, like the wire needle localization, they'll put a wire or a needle into, and it's usually done on ultrasound or something like that. They'll put a needle into the mass and then they thread a wire into it. They'll take the needle out, leave the wire in, and then send the woman to surgery. So the surgeon knows exactly, based on that wire, which piece of breast tissue to take out, because sometimes they're very, very tiny. They're hard to see with the human eye, but they really want to make sure that they get the tissue that they're looking at, because worst case scenario is you get a biopsy of healthy tissue and miss the malignant tissue that's right next to it. So they do need to be very precise about which piece of breast tissue they're taking. If the patient is going for these biopsy procedures, especially the bigger ones that require surgery or sedation, and where they're taking out more tissue, things that you would need to teach your patient ahead of time is to reduce anything that's going to cause bleeding. So they need to stop Motrin. If they're on heparin or aspirin or something like that, they need to stop that ahead of time. And some of the herbal supplements that people think are good for them, which they can be good, but they can also increase bleeding times, like vitamin E, vitamin K. Somebody who has lots of spinach, because spinach has a lot of vitamin K in it, they need to not have those things before surgery. Okay. So then what happens is the patient will go for biopsy, and then they'll figure out exactly what they're dealing with. And then based on what they're dealing with, we'll determine next steps, like what treatments are going to happen next. And I think, I'm going to come back to that. I'm going to move into some of the benign breast disorders, because I wanted you to distinguish, especially when we move into the diagnostic procedures, the difference between a malignancy and just fibrotic breast disorder. Because there's a lot of breast disorders that involve masses and things that are not malignant. For example, and now I moved over to page 16, 90, and 91, cysts. A lot of women have fibrotic cyst disease. Fibroadenomas, those are not malignant. Hyperplasia is just like the cells are starting to change, but that doesn't necessarily mean that they are malignant cells. Lobular carcinoma in situ. When you see something that's in situ, that means it's not cancerous yet, but we're going to watch it because it could be cancerous. So in situ is not a malignancy. It's like when I was telling you about like a pap smear that comes back with dysplasia. It's not cancer, but we're going to watch it because there's a high risk that it can be. So most of the malignancies in the breast are ductal. They start in the ductwork of the breast, but the breasts are almost all ductwork. So when they send a woman for a biopsy, and it'll come back as one of these things, you've just got a cyst, or you've got a fibroadenoma, or atypical hyperplasia, or something like that, then it just gets documented, and then that woman really doesn't have to have any additional treatment. You do have to find out, like, are you taking some hormones that might be contributing to this? Or what is your diet like? Are you exercising? Can you are there other ways that we can improve that woman's health? But they don't necessarily have to go for surgery, definitely not chemotherapy or radiation at that point. Okay, so now let's move into, on page 1692, now let's say that one of those biopsies come back that it's malignant. Now, the staging matters and the grade matters, and there's a difference between staging a malignancy and the grade of the cancer. When you stage a cancer, they use the TNM system, which I'm assuming you guys learned in Med-Surg 1. The tumors, the nodes, and the metastasis, the TNM system. So when you stage a cancer, and this is true for any cancer, in breast cancer like we're talking about now, like stage 0 is non-invasive, and by that I mean it hasn't starting to spread, and it's just really localized. That's stage 0. I think, isn't there a I thought there was a table in here, but maybe not. All right, I'll find it and I'll bring it into class, because it's kind of important to know stages, just kind of off the, because this is true for any kind of cancer. But stage 0 is real localized. You can get it out with surgery. You might not have to have radiation or chemotherapy. Stage 4 is extended beyond where it started. It's in the surrounding tissues, it's in the lymph nodes, and it's metastasized somewhere else. So it goes on those stages. So obviously the earlier stages, the better. But the grade of the cancer also matters. So for example, hang on a second. Like a low grade breast cancer is way less aggressive than a higher grade breast cancer, because the higher the grade, typically the more aggressive and angry that cancer is. So like this is true. It seems to be that age matters as well, because the younger you are when you develop a malignancy, it tends to be more of an aggressive cancer. For example, if you get colon cancer when you're 40, you are more likely to die of it because it's a higher grade, more aggressive kind of colon cancer than if you get colon cancer in your 70s. They're still both colon cancer. They're still both probably like adenocarcinomas, but the grade is higher, and so that makes it more aggressive. And the same is true with breast cancer. And in breast cancer, we know that if women are carrying the BRCA gene, and there's the BRCA gene 1 and BRCA gene 2, and if a woman has a family history of first line, either mother, sister, daughter, that have had breast cancer, and they're carrying the BRCA gene, those are higher grades and tend to be more aggressive than people who don't have the BRCA gene. So that's just to make you familiarize with the difference between a stage and a grade when we're talking about malignancy. The invasive cancers are they're the ones that are starting to infiltrate into the breast tissue, and there's a bunch of them. Infiltrating ductal carcinoma is the most common one in breast cancer. I do want to point out Paget's disease, which is at the bottom of the invasive cancer list. Paget's disease is rare, but it shows up differently than the other ones. It looks more like mastitis. It looks like an infection of the breast tissue, whereas the other cancers don't, you know, you can't really, sometimes you can't tell unless you can feel them, but Paget's disease sometimes is red, inflamed, angry, and it's also a carcinoma that needs to be removed. The reason I'm telling you this is because a couple years ago, one of my friends on Facebook or whatever posted this picture of a woman who had, you know, like this, it was untreated Paget's disease is what it was. She had a malignancy in her breast. She didn't get it treated, and it started spreading and got necrotic, and it was just this awful looking thing. And the caption was, ladies, wash your bras because of this flesh-eating bacteria. Well, okay, first of all, the reason I'm telling you this story is, as a healthcare professional, you need to be very cautious when you're seeing stuff like this, because as soon as I saw it, I knew it was Paget's disease, not you know, somebody that didn't wash their bra. You cannot have like a new bra from the store that you didn't wash and get Paget's disease. So be careful when you see stuff like that, because with social media, this kind of stuff is rampant. So just use your head and, you know, what you know, and educate the population, because washing your bra is not going to help prevent malignancy. Okay, so there's not really a risk factor for breast cancer. They don't know why it shows up. There's a lot of it in the United States, as you know. So there's another thing is, there's a lot of talk now, like in social media and stuff, about not using antiperspirants, not using deodorant. They say that contributes to breast cancer. That is not true. Studies have not shown that. You can tell your female patients that deodorants are safe to use, and that would help just the rest of us. So there are some risk factors, obviously being a female, although men can get breast cancer, and if a man is from a family whose women have BRCA genes, they're more likely to develop breast cancer. Okay, so once a person has been identified that yes, in fact, that they do have a malignancy, the treatment of choice is surgical removal of the mass. Now, sometimes if it's staged higher and it's in the lymph nodes, and there's a good picture on page 1694 in figure 58.5. You can see how significant that lymphatic system is. It drains a ton of lymph nodes all in this area, and you can feel your lymph nodes up in here and under your arm. There's a ton of them. So what they'll do is they'll take up the patient to surgery, and they will remove the tumor. And then what they do is, while they're in surgery, is they will start taking the lymph nodes that are around that tumor, and they will send them to the pathology lab. The goal here is to have no lymph nodes that show evidence of a malignancy, because the more lymph nodes that are involved is a prognosis of how that woman is going to do. So if she has 0 lymph nodes that are positive for malignancy, her prognosis is much better than a woman who may come back with, 3 out of 8 lymph nodes are also positive for carcinoma. That prognosis now starts going down, because now it's already in the lymph system. And if it's gotten to one lymph system, these microscopic cells may have gone somewhere else. So there are some review chart 58.4 about some prognosis for breast cancer. So obviously, the less invasive it is, the fewer the lymph nodes that are involved, the more localized it is, the presence of a BRCA gene or not, those things all matter in how the woman is going to do. Because some women with pretty good prognosis factors can end up, they'll take the breast cancer out and they can live a full, healthy life. Women that have lower prognostic values, meaning it's invasive, lymph nodes are involved, BRCA genes involved, their prognosis is not as favorable, and their treatment is going to be more extensive. So once they take the tumor out, if they find out that it is non-invasive, it's localized, and margins are clean, meaning there's no cancer around the margins, the patient, that may be all the treatment the patient needs. If it is spread a little bit, they might just do some radiation. But if it's massive, they may do a complete mastectomy. Some women are choosing to have preventative mastectomies even before they find out that they have a malignancy. The most famous person that did this is Angelina Jolie, because she's carrying the BRCA gene. And her mother and I think a sister, or she had a lot of really close female relatives that developed breast cancer, and she had the gene, so she had a prophylactic bilateral mastectomy, where meaning she had both breasts removed to eliminate her risk of getting breast cancer. And the thing about that is there are such awesome reconstructive surgeries now. I do want you to know about the kinds of, where is it? Surgery. I thought it was in here. Isn't there? Oh yeah. Go over to, I'm jumping ahead, but over on page 1707, this is a person who's had she had a unilateral mastectomy, meaning complete removal of the breast and lymph nodes in that area. And they can do some really good reconstructive surgeries now. They can take muscles either from the back or the rectus abdominis muscle and reconstruct the muscle behind the breast, and they can tattoo areolas on, they can put silicone implants underneath, so you really can't even tell, especially from the outside, that a person has had reconstructive surgery. So there's a lot of really awesome treatments now for women who are choosing to have mastectomies. The one thing about a woman who has had a mastectomy, again, it is a lot of psychosocial conversations with that woman, because that's what makes a woman is, the presence of breasts. And so the loss of that can be very significant. So you really need to talk to your patient about that, find out, they make bras now with, like one side has like a silicone implant just built into the bra if a woman doesn't want to have the complete surgery. So there's a lot of options that women can do, and you need to talk to your patients about that. Sometimes if they've had what's called a radical mastectomy, meaning they take the breast tissue, the muscle underneath it, and all the lymph nodes, you have to be very, very careful, because if you go back to that picture with all the lymph nodes in it, the lymph nodes that are a ton up here drain down into the arm, and those patients are at very high risk for lymphadenopathy the rest of their lives. So if your patient who's had a mastectomy, you have to be very careful to protect that arm. So you don't get blood pressures in that arm, you don't draw blood in that arm, you use the other side, which obviously is problematic if your patient has had a bilateral mastectomy. Now you have to come up with some other options, like you could do a leg. Sometimes they're making blood pressure cuffs big enough for the leg, or just use a lot of precautions like compression devices, like the TED hose on the legs. They make compression sleeves for the arm. A woman should be taught to do a lot of exercises, and you can see on page 1700, chart 58.7, some of those surgeries where, exercises where a patient, walks up and down the wall with her fingers because you just want to keep those muscles working, because you're trying to prevent lymphadenopathy. Okay, so then afterwards, so the patient's had surgery, and then they may have to have radiation. And remember that radiation goes to a specific spot. It could be like putting in seeds, like in uterine or prostate cancer, or the radiation beam, which is more likely in breast cancer. They would do beam therapy. Or if it's spread, and once it's got into the lymph system, they usually do chemotherapy, because chemotherapy is systemic, and it will affect the entire body. Radiation will just affect one area. So if it's in the lymph system, they usually have chemotherapy. When your patient is on chemotherapy, now you have a whole nother set of problems that you're trying to deal with. One, you can chemotherapy targets fast-growing cells, so all of the cells that turn over quickly are affected, which is why patients lose their hair, they lose their fingernails, they have a lot of nausea, vomiting, diarrhea, because your GI tract changes very quickly. Every 3 days it replaces itself, so they have a lot of GI problems. Additionally, there's a lot of bone marrow suppression that can occur, and you can find that out by checking somebody's thrombocytes. Thrombocytes should be greater than 150. When those thrombocytes start falling, they might start having some bone marrow suppression. They can have white blood cells. They can start dropping because it's immunosuppressive, so it can drop their white blood cells down. Normal white blood cells are 4 to 10, so when it starts getting less than that, you need to be very cautious that your patient's not getting infection. You need to take temperatures often, keep them away from other sick people. They can get anemic, so you follow their hemoglobin and hematocrit. Normal hemoglobin is like 12 to 18. Hematocrit is like 38 to 52. Those, both hemoglobin and hematocrit, they change quite a bit on age. So the lower end is for women, and the higher end, men should be in the higher end there. So there are some good drugs now. If your patient is on chemotherapy and if they start dropping their white blood cells and they're at high risk for infection, there's a drug called Neupogen that kind of helps boost the white blood cells. Erythropoietin, I've told you about this one before, stimulates red blood cell production. Epogen is the other name, the other brand for erythropoietin. So sometimes when your patient's lab values start dropping because of chemotherapy, then you have to start adding different pharmaceutical agents to help boost whatever it is that is problematic because of chemotherapy while you're trying to eradicate the cancer cells. So, you know, kind of look over that. Tamoxifen. You know, tamoxifen is this is a drug that came out a while ago, and it was showing quite a bit of promise in women that have breast cancer, and so much so that in Europe, they have socialized medicine, and they will only they're not as quick to give out like new trial drugs and stuff. They were not giving out tamoxifen for women that had breast cancer because they said it wasn't proven yet. It was, you know, too new. Well, the women, I can't remember if it was France or where it was, rose up against the government like, hey, this isn't fair. We want this drug. The American women are showing a lot of success with it. So, and I guess so much so that then, I think it was France or whatever, said, okay, then now they started to pay for tamoxifen. So that is showing that it does have some side effects, but the risks totally outweigh the side effects, usually in most cases. So a lot of women are trying this tamoxifen. Okay, and then I already told you about some of the different reconstructive surgeries. I already talked about that. The only other thing I wanted to point out is that while this is predominantly a male issue, while it's this whole lecture is mostly geared for women and your female patients, it is true that men can have breast cancer. Like I said, it runs in families. And two, there's this thing called gynecomastia, where men develop female-like breasts and overproduction of breast tissue. You see this in obese males as well as males who smoke a lot of marijuana. So if you have a male patient and, you know, in his adolescent years, this actually happened to a friend of my son's. He's a hockey player with them, but he was also, this is horrible to say, but it's true. He was like known as like the pothead. He was the kid that would smoke pot all the time, and everybody knew it. Well, he started developing female breasts. And so much so that his parents would come talk to us at these hockey games, and we, of course, knew probably what the cause was, but we didn't want to tell the parents that. But he did. This kid was 17, I think, 17 years old, and went for surgery to remove breast tissue because he was developing gynecomastia. That kid is in college now, and from what I hear, he's still smoking pot. But I don't know if anybody ever told him that that's the cause of it. I certainly didn't tell him because my kids told me I couldn't, even though that's probably the cause. So, okay, so that's it for this chapter, and then we'll do chapter 59. We will talk about the male reproductive.